Well, dear colleagues, welcome to our monthly dialogue. Now we have more than 40 dialogues, and this initiative of the European Art Journal has been very successful. And the reason because it's been successful, I believe, is because during these dialogues, we host the leaders, the top experts of cardiology from the 5 continents, and we try to unveil not only their scientific side, but also their human side. And I think that this is a source of inspiration for all of us and for our younger colleagues in particular. So the goal today, as with the other dialogues, is to discover our important guest, his scientific contribution, and also his human side. Today, as usual, we have a very important guest. He contributed significantly to the history of cardiovascular medicine. And the topic we will discuss with him today is very, very relevant. Ischemic heart disease. Ischemic heart disease, in spite of our efforts, remains the #1 killer. So we have to do more. And what has been done by our guest, Andreas Zeiher, his contribution to the knowledge of ischemic heart disease has been really and is really outstanding. We have done incredible step forward, but a lot remains to do. And today we will have with him, we will review with him the history of ischemic heart disease, the past, the present, and the future. I will host him with Raffaele de Caterina, Executive Editor of the European Art Journal. And first, welcome, Andreas. Thank you for accepting our invitation. And Raffaele, can you introduce our famous guest, and then we will start with our questions.
Good afternoon, dear colleagues. Sorry for my bad voice due to a laryngitis, but I will speak not so much and leave the floor mostly to Andreas, our distinguished guest. Just a brief outline of his CV, his outstanding CV. He's currently Emeritus Professor of Medicine and Senior Cardiologist at Goethe University in Frankfurt, University Hospital Frankfurt. He's specialized in clinical cardiology, interventional cardiology, angiology, and molecular cardiology. Andreas started his medical school at the University of Freiburg, where he graduated in 1981. Then he was a research fellow at Cedars-Sinai Medical Center at the University of California, Los Angeles, UCLA. In 1990, he became associate professor and director of the interventional cardiology laboratory at the University of Freiburg. And then in 1995, he became chairman and director of the department of the third department of medicine, cardiology, angiology, and nephrology at the Goethe University in Frankfurt. Andreas has been president of the German Cardiac Society between 2019 and 2021. He has served on the editorial boards of leading journals, Circulation, Circulation Research, and our European Heart Journal, and is recognized as one of the most cited authors in European cardiovascular research, focusing extensively on vascular biology, endothelial dysfunction, translational approaches to cardiovascular regeneration, including adult stem cell therapy. So with this, welcome, Andreas, and I will start interviewing in this very informal way, trying to catch, as Filippo said, the human aspect of your career, because this will be of interest for the young cardiologists that pursue our wonderful discipline. So, Andreas, I know that your first studies were on arrhythmias. Was arrhythmia that attracted you mostly to cardiology at the beginning?
Well, first of all, thank you very much, Raffaele, and thank you very much, Filippo, for the invitation. I'm really excited to be here, and I hope I can contribute to understanding what is behind the persons who are writing papers and doing science. And to answer your question, Rafa, no, this was just by accident, because this was in my first year as a fellow at the University Hospital in Freiburg. And this was a time in 1981 when class 1A arrhythmias became very popular. One of those was flecainide, which is still used in some patients. And at that time, we used it for treating premature ventricular extrasystoles. And most of these patients actually did get a 24-hour Holter monitoring report after initiation of therapy to look at the effect. And all of a sudden, we realized that in one patient, I think it was patient number 2 or 3 in the study, actually he died from ventricular fibrillation induced by flecainide. So this was a case report out of clinical observation, which led to my first publication. The real reason I went into cardiology came a bit before, because during my studies at the university in Freiburg, you have to know, Freiburg was dominated by environmentalists. We were very green, we were very left-sided in our political opinion at that time. And I initially had the idea to become a psychiatrist at the time, but then during my practical year, there was a guy presenting a talk at Konstanz, where I did my practical year. And this was actually my later boss, Hans Just, and he was a cardiologist. And he gave such a fantastic talk for me that I decided maybe this is what I want to do. And that's why actually I tried to get a position in his department and finally was successful. So this was the initial firing of becoming a cardiologist.
So this is interesting, Andreas, because for many of us, there was an initial element of serendipity, of case, after which necessity came out and pushed us towards our careers.
Yeah.
So I would like to ask you more about your mentors at the time you started your career. You mentioned Professor Just.
Yes.
Can you tell us more about which figure acted as role models when you were a young cardiologist or wannabe cardiologist?
Yes, I can. Well, I have to start with my former boss at that time, with Hans Just. He was a brilliant clinician. He was actually spending about 10 years in the US. And at the time he was there, the late 60s, early 70s, there were no echo, no imaging modality. So he was brilliant in using his stethoscope for auscultation. He could actually predict more or less very precisely what the grade of a mitral valve stenosis is, just by looking at how close the mitral opening tone is to the second heartbeat. And he was a very, very prominent role model for me in clinical cardiology. Later on, I have to admit, I discovered that he cheated sometimes with a stethoscope, because when we were on grand rounds, and he always were using the stethoscope first, and then he asked us, "What do you hear?" And most of the time he said, "Andreas, don't you hear this split first heart sound?" And I had no idea what he was talking about. Later on, I discovered that he always, before auscultation, he looked at the ECG. And when he did see a left bundle branch block, he came up with this split first heart sound. So sometimes you have to look a bit deeper in detail. Anyway, he was for me a brilliant clinical teacher, and he had one other wonderful side. He was not an interventional cardiologist, which later gave me much more freedom to develop my interventional skills and finally become the head of the interventional cardiology program at Freiburg. Because you have to know, in the German university system, the boss is still the boss, but if he doesn't do interventions, this gives you a bit more free room. My most important mentor in developing my skills was actually Tassilo Bonzo. I'm not sure that many of you will know him. He actually invented and patented the so-called monorail catheter, which is now known as the rapid exchange catheter. At that time, for those who are not in interventional cardiology, we had wires of 2.5, 2.7 meters long on the cath table to exchange a balloon catheter, because the wire was running on the entire length of this 120, 125 long catheter. And to exchange it, you obviously had to have double of the distance at least to do so and leave the wire in the coronary arteries. And Tassilo, while visiting the monorail system on Disneyland, he came up with the idea, well, the wire doesn't have to run on the entire length within the balloon catheter, but maybe it's sufficient to have the last 10 or 15 centimeters within the guiding catheter. It doesn't make any difference whether you have two things, a wire and the balloon catheter in parallel. And I was actually fortunate to do the first procedure at that time. This was late in '85, together with him in the cath lab, which was really a historical moment, a very spectacular moment. In terms of my enthusiasm for basic science, which I still have, I would love to mention Rudi Busse. Rudi Busse at that time was the physiologist, cardiovascular physiologist in Freiburg. He was heavily involved in studying endothelial cell function, and he actually first developed, described, and disclosed the mechanism how arteries dilate in response to increased shear stress. And he also became a colleague later on in Frankfurt because he was appointed there as professor of physiology. And then outside of my institution, I have only one mentor which inspired me majorly, and both Rafa and Filippo, you know him very well. This was Attilo Maseri. Attilo actually, more than 40 years ago, really fundamentally changed the view on coronary artery disease, or more broader ischemic heart disease. He came up with the idea of the dynamic ischemia phenomenon, both on the large coronary arteries as well as the microvasculature. And he also was the first actually to nicely describe an important role of inflammation for acute coronary syndrome, which we are still working on heavily. And what I loved most, that he did papers in the New England Journal with 15 or 18 patients, very well observed, very beautifully studied, coming up with brilliant hypotheses proven in these highly selected patients. So he was really a mentor and I have to say, an idol for me. And he was stimulating me to much of my ongoing research work in the clinic at that time, especially in the mid-80s up to the mid-90s.
Yeah, Andreas, you mentioned something regarding the stethoscope and the use of stethoscope that was done at that time. And I'm very curious about your ideas of whether is it still useful to have these old-fashioned tools in cardiology, and we still need to train people to use the old-fashioned tools like the ears, the stethoscope, or shall we forget everything about that?
I'm completely convinced that it's still necessary and very important. And this is especially important in emergency kind of situations where you want to diagnose, for example, heart failure, acute heart failure, and this kind of things, which you can easily do by using a stethoscope. In terms of quantifying valvular disease and so on, obviously imaging has much better capabilities and is much more precise and also allows for sequential examination to assess progression. But in the acute phase, I think every cardiologist needs to know what a third heart sound is and needs to hear it. And I think therefore, yes,
Yeah.
it's still necessary.
You know that now in the US it has been documented that fellows can
I
hear
know.
the heart sound like tossing a coin, and it's no longer taught carefully, and I think it's a mistake. And I'm glad that you share this
Yeah.
idea that we need to build up on old knowledge, but
Yes.
not forget about the past. So you mentioned Attilio Maseri as one of your mentors or inspirators at that time. So this was you were interested in ischemic heart disease from the very beginning, from soon after this arrhythmia priming that you had. Was this
Yes.
very early on?
Yes, I was. Actually, as Filippo already mentioned it, at that time, it was even more pronounced, the most important cardiovascular disease. And it was also a time in 83, 84, 85, where we started to intervene in patients with acute myocardial infarction. And if you experience that once you reopened an artery by catheter or by thrombolysis, we did at that time intracoronary thrombolysis, symptoms immediately disappeared. So it was a wonderful feeling actually to help patients. And this actually guided me to work on more understanding the ways behind ischemic heart disease, how it develops, how it actually exacerbates, and how it finally culminates in this catastrophic event of suffering from a myocardial infarction.
And you mentioned Rudy Busse as one of
Yeah,
your mentors. I also used to know him at that time. Nitrates were the
exactly.
focus of a lot of attention in cardiology, and this eventually led to the discovery of endothelial dependent, endothelial independent vasodilation, which I think is still something extremely important in ischemic heart disease to characterize functional aspects
Yeah.
of ischemic heart disease. Do you want to elaborate more on this?
Yeah, I'm glad to do so. And I think it's really important for everybody to understand coronary physiology and coronary vasomotion in a broader sense, whether endothelium dependent or independent, is a major component of that, both in the large epicardial arteries, but specifically in the microvascular circulation. And it's actually still relevant in this new entity of patients with angina, but without obstructive coronary lesions. So I think at the time then, this was in 88 and 89, when we started to do this functional testing in the coronary arteries, it was exciting times to actually see that we can reproduce what experimentally has already been shown. We could show flow-dependent dilation. We could show the dilation in response to acetylcholine if the endothelium is still functional. I think from a diagnostic point, the intracoronary testing is much too cumbersome. So it's probably not a routine clinical method anymore. As I said, it's most likely preserved to those patients with angina, but no obstructive epicardial artery disease. And there it also might guide some therapies in order to see whether you can improve specifically microvascular function with different pharmacological interventions. I
And
think
sometimes also in MINOCA, in myocardial
exactly,
infarction with
exactly.
non-obstructive coronary arteries, which is an entity that many cardiologists disregard at the moment, saying
Yes,
that good prognosis may be just a pat on the back of the patient, but it's an infarction, so it needs attention to the cause. And one of the causes, one of the many causes, is
yes.
vasoconstriction that can be unmasked by the functional testing.
Yes.
It was
But
to me.
I think, Rafa, at that time it was also extended to the peripheral circulation. There was flow-dependent dilation in the forearm and acetylcholine infusion and assessing plethysmography, where also Tom Lüscher heavily participated and contributed to, and Filippo too. But I think this has more or less disappeared from a routine clinical test to assess risk because we learned at that time that more or less every single risk factor we know for coronary artery disease goes along with an impairment in endothelial function, which at that time also was important to realize and to know and to establish.
Yes, I completely agree. That time was quite an interesting research field, but now just putting together traditional risk factors do the same as measuring this much more cumbersome test.
Yeah.
So I would leave the ground briefly to Filippo to say and to question you on some other aspects of your brilliant career.
I know what is coming now, Filippo.
Yeah, but before that, let me comment, Andreas, on what you said, which is extremely important. And let's start with the concept that the three of us, we had a common father. And this is the beauty of the academic life. This transition from mentor to mentee, and the mentee
Yeah.
becomes the mentor. I mean, this is unique. It's really fascinating, can feel alive. And in our time, it's even more because this is on a global scale.
Yes.
100 years ago, the principle was the same. Mentorship in the academic life was the key. But now, in the last 20, 30 years, this has been possible on a global scale. So your natural father, so to speak, was in Germany, but Attilio Masseri became a sort of a second or third
Exactly.
acquired father. So this mentorship process and on a global scale makes academic life really unique and very attractive. I think this is an important message for our
Yeah.
younger colleagues. And another member of the Masseri family is here, is Carlo Patrono. Carlo, I think it would be nice to have a comment from you and a question for Andreas.
Okay.
Hi,
Can you hear
Carlo.
me? Hi, Andreas. It's very nice to see you and to hear your voice and the history of your life. Of course, I spent a year with Attilio in London as a visiting scientist and learned a lot from him. Being a clinical pharmacologist, working in his department was an entirely different view and opened my mind to clinical issues that I had not considered before. The question I meant to ask you comes from my background in clinical pharmacology and the interest in new drug development. However, what I've seen during the past decades is that cardiology has been very good at decreasing the rate of major vascular complications after a myocardial infarction from 5 to 6% 30 years ago to down to 2%. And yet, people keep developing new drugs and adding on top of existing agents. Now, when you reach a 2% annual rate of major vascular events, if you add another agent that reduces further by 20-25%, you end up with a number needed to treat of about 250 patients. Can we, as a European society, afford such a luxury, or should we concentrate more on optimizing the use of the tools that we have already available to us?
I think that's a very important question, which was actually intended to come to it later. I also do believe that in the acute myocardial infarction situation, we have more or less reached a ceiling in terms of the aggressiveness of platelet inhibition. We have reached a ceiling that we have tools to reopen arteries acutely. We can become better in bringing patients faster to the hospital on the cath lab, providing more or less full service on every areas, also on rural areas. But I think the most important aspect would be that they do not end up on the cath lab table because they do not suffer from an infarction. So the most important task we have currently, I do believe, is to prevent progression of atherosclerosis towards an occlusion leading to an acute myocardial infarction. Yeah.
Thank you.
Thank you, Andreas. Very, very important point. I see other famous colleagues in the room, Jan Piek, Luisa Arbustini, and Diana Gorok, among the others. Please be ready to ask questions to our famous guest. But I start with another question. Well, more than 20 years ago, our interest, Andreas, was attracted by cell therapy.
Yes.
And was also a strong emotion. The idea of treating the heart using cells was absolutely new. Well, after 25 years, what is the legacy of this line of research?
Well, first of all, I think we all were absolutely excited by Jeff Isner's science paper in '97, where he actually suggested there are circulating endothelial, they called it progenitor cells, which might contribute to angiogenesis. And then it was still very controversial at that time, but there were some data that some of these cells come from the bone marrow, and maybe we can use or enhance the circulating number of these cells in the heart simply by taking them out of the bone marrow or even out of the blood and reinfuse it directly into the coronary arteries to enhance their, in quote, more or less vascular repair capacity, which we hope then should translate into an improvement in pump function of the heart, specifically after myocardial infarction, potentially also in heart failure. I think at that time already many of us believed that might be a paracrine effect of the cells and not the cells themselves, because the number was still very much too small, which actually were retained in the coronary arteries. But we have to admit that after 15 years of investigating these therapeutic options, we did not succeed to improve outcome in patients, even with large myocardial infarction, if we use these unmodified cells from the bone marrow, purified them and reinfused them into the coronary arteries with respect to improved prognosis or reduction of mortality. But keep in mind that the pharmacological therapy in these last 15 years also has led to a more than 50% reduction in mortality in heart failure. So we were actually competing with this major progress. I think for the future, we have learned a lot about this, and we also learned a lot recently because we now know that not all cells taken from the bone marrow are the same. Some, which I come later on, do have mutations, are more inflammatory, may actually harm when we infuse them into the coronary arteries. But at the time being, I do foresee no role for an unmodified cell therapy in cardiovascular disease. I personally believe that we should focus on mechanisms of endogenous regeneration. We might come back to a cell infusion therapy if we find a way to isolate what we call reparative macrophages. We do know that there are reparative macrophages in the heart. Some of them are resident in the heart. Some of them may come from the bone marrow. We are potentially not yet as far to characterize them, but this potentially would be a way to go. But at the time being, the only way where cell therapy is still applied is in so-called bioengineering methods, where you construct patches of a heart tissue and then insert that most of it surgically onto the heart surface to interfere with chronic heart failure. Obviously, this is no option for patients with acute myocardial infarction because it takes too long to make these patches.
Yeah, Andreas.
But I think we learned a tremendous amount. We did get tremendous information about that, and it also opened up a field which is now very popular, that the bone marrow itself, by releasing these cells into the bloodstream, which then circulate through all organs, might play a major role also in deterioration of patients with cardiovascular disease.
Andreas, just by serendipity, this morning I was browsing the latest issue of the New England Journal of Medicine, and there was this publication by mostly a German group. Stefan Anker was the last author about this BioVat HF study, by which these patches were constructed with induced pluripotent stem cells implanted on the epicardium of diseased large anterior myocardial infarction in patients, and with an apparent improvement in prognosis. So, is this something that you share as a view?
Yes, I'm very aware of the study. The study is also part of the German Center for Cardiovascular Research, where I'm a member of it, and it's also mostly financed by it. I think this is an option, but it will be an option for a small portion of patients, because most of it is very expensive to be prepared, and it needs a surgical approach. But for some patients, this might be indeed a future which we should not neglect. And given the advantages in bioengineering and constructing these patches of tissue, which is incredible how fast this has developed in the last 10 years, this might be something which we should have an eye on, at least for some patients where there are no other options. Yes.
Great.
Well, in addition, let's say, in a sense, a legacy of cell therapy, secretome-based therapies, which are currently under development, I mean, is along that line of reasoning. So I think that this experience with cell therapy per se didn't work, but was important to show that they do not work. But it opened new avenues, and what Raffaele said, and secretome-based therapies, I think that can bring us good surprises in the future. So it's, again,
I completely agree. Yeah.
It's the beauty of science, as we said before, from mentor to mentee, from one discovery to another, and even something doesn't work, but generates questions, and these questions generate answers, which at the end make life of our patients better. I see another famous guest in the audience, Jan. Jan is always with us with our dialogues, and always with interesting questions. Jan, any comment or question for Andreas?
Well, first of all, it's a pleasure to see Andreas now in this meeting. Can you hear me now?
Yes, perfect.
So we will listen a little bit. You already elaborate a little bit on cell therapy. Were we just a little bit too early with our initial approach? You already mentioned maybe that we maybe should also focus on the more harmful effect, for example, of classical monocytes that maybe are just as maybe important as the positive effect of, already mentioned, the limited number of cells that were injected into the coronaries. But should it not be focusing to the harmful effects, for example, as classic monocytes? What are your ideas?
I completely agree with what you said. And in essence, if we would have known that probably 50% of our patients we treated at that time had this clonal hematopoiesis mutations in their circulating monocytes, and obviously also in their bone marrow-derived cells, which we then use to reinfuse. And we know that some of these mutations really drive these monocytes to become highly pro-inflammatory. We would probably have changed a different approach. And this is what I mentioned with that we probably need to identify more, in quote, reparative kind of macrophages by some surface markers, but this is still experimental, and we have to still find out whether we then get these cells in sufficient numbers into the heart and that they are retained there to exert their effects. So it might probably better actually to interfere with the immune system or use some immune modulatory kind of treatment, which directly also attacks and targets these cells in the bone marrow. So when they come out, they are probably more beneficial in terms of repairing the heart because they circulate with the blood. When the progenies are out of the bone marrow, they will reach the heart and hopefully could do something there. But I think this is far-fetched, and we have to see whether this actually can make a major difference. I'm still convinced that there might be ways of endogenous regeneration, but yeah, we have to find out.
Yeah, well, thank you very much.
Hey, Luisa,
Thank
hello.
you.
Hey,
Alois is there. She raised her hand. Please, Aloisa.
No, it's a consequence of this comment. Should we expect more myocardial infarction in carriers of somatic, for example, JAK2 mutations in hematological setting? Because this is something that we don't see. We don't see this higher prevalence or incidence of acute ischemic syndromes in these patients. So everybody now is waiting, I don't know, for something that is not coming out.
Depends a bit, Luisa, on the mutation you do induce. And if you talk about hematological patients or cancer patients being treated with cancer treatment, cytostatica treatment, they do not actually develop other mutations like TP53 mutations and so on. But there's absolutely no question that if you do have a JAK2 mutation as well as a TET2 mutation, your risk for an acute ischemic cardiovascular event is increased by about 15 to 20%.
So, accordingly, should they be treated?
This is what we still have to show. We still have to do, and we are starting this kind of trial, whether in some of these mutation carriers, a specific, in this case, anti-inflammatory therapy actually improves prognosis. At the time being, we have no data, but we definitely should maximize secondary prevention or even primary prevention in these patients with what we have available, namely statins, low-dose platelet inhibition, and maybe even angiotensin II blockers. Yes, I personally believe this is the way to go.
Do you expect that the phenotype of the acute coronary syndromes in these patients is the same as in those who are not carriers of somatic mutations like that? Or do you expect for something else, more platelet-related acute thrombosis? Carlo probably can also answer.
So if we do believe in the inflammatory hypothesis, which mainly relates to TET2 chip driver mutations, I do believe that those patients do have more vulnerable plaques and more eroded plaques. It could be that in the presence of JAK2 mutations, if you have endothelial erosion, which is also a mediator of acute myocardial infarction, may play a more prominent role because JAK2 mutations are most likely inducing a pro-thrombotic and pro-platelet aggregatory effect at the site of the denuded artery. But I think this is what I believe. It has not been tested yet. We do have the tools for that because with the new photon counting CT scanning, we do have actually chances to look at different plaque types. And I'm sure that we will, in a few years, know better what kind of plaque characteristic, if there is a specific one, may relate to the presence of one of these mutations.
Thank you.
Andreas, we have a question from the audience.
Yes.
It is a bit unrelated to this, but I want to hear your sense of what lipoprotein little a will bring us in terms of possible therapeutics? What is your crystal ball in this case?
The crystal ball is very clear. We do know from epidemiological data that Lp(a) is an independent risk factor, both for coronary artery disease and especially in women, also for carotid stenosis. But we have to await the ongoing trials, which are ongoing with very potent drugs reducing Lp(a) levels, these siRNA drugs working on the liver. And unless we do have this data, we still have to wait. I think it's the same with our HDL kind of story, where we were convinced that increasing HDL will reduce cardiovascular event rates, ischemic event rates, but it did not so. But my expectation is that since these drugs are powerful, there might be a beneficial effect. But let's wait for another year, then we have the data of the first, I think, 15 or 16,000 patient trial, high-risk patients, and then we can say more about it.
Yeah, I see a question from Diana. Diana Gorg is here. Please, Diana.
You're
Can
still
you
muted,
unmute,
Diana.
Diana?
Can you unmute?
Yes,
now.
yes, thank you. What an inspirational talk. Thank you so much. I wonder if I could ask two questions. The first is a rather generic question, but to you as in your career, how have you managed to balance the needs of maintaining your clinical skills, staying clinically active, but also doing research? And has that evolved over your career? Has the balance shifted? And the second part, what are you working on now?
Well, first of all, to have this balance, you have to have wonderful collaborators who are doing actually the experimental work. And I have to admit, I never did work in the lab by myself, so I never used a pipette. I had hundreds of ideas what could be done, but I had a fantastic team, both already in Freiburg with Rudi Busse and then in Frankfurt with Stephanie Dimmeler, who was able actually to transform the ideas into and materialize it into results. I love at the beginning coronary physiology and coronary biology. So I was always driven by understanding the mechanisms, specifically pathomechanisms. So it was natural that I was reading always these basic science journals, Nature, Science, you name it, Cell, in order to understand what could be potentially relevant. And on the other hand, I loved to be an interventional cardiologist, at least till the last 5 years. So when I turned 61, 62, I was not so eager anymore to spend 8 hours in the cath lab. But I still love to do procedures because it's extremely rewarding. Because most of the times, not always, but most of the time, you really immediately help a patient. Whether it's long-term benefit or not, doesn't care. But for example, if you have somebody who has angina, even stable angina, you remove the obstruction. The next day, there is no angina. If you treat an acute myocardial infarction, symptoms disappear immediately. If you implant an aortic valve, they walk up the next day and have no compression and no bad feelings. So yeah, it's both of it, and I would not miss anything of it. But I have to admit, I had a rule that on Friday at 2 o'clock, I closed my office, I sent home my secretaries, and I spent 2 to 4 hours on the computer and downloaded a lot of basic science paper to be read over the weekend in order to understand what these young people in the laboratory and in the basic science department were actually doing. So yeah, it has to be enthusiasm, and I think the most rewarding thing is that you can actually motivate and bring young people to come up with those brilliant new ideas and put this into practice. Yeah.
Andreas,
Yeah.
what is your, at this moment, this stage of your career and in your life, what is your main scientific goal at this time?
Well, that's actually very easy. I'm still inclined to ischemic heart disease, and myocardial infarction and coronary artery disease, and we have a myriad of risk factor, but we have still one risk factor which is by far the most important, and this is age. And in every paper you read, age is an unmodifiable risk factor. And I personally do not believe this. And this is why I'm so avidly working and inspired on working on these clonal hematopoiesis kind of phenomena, because those are strictly age dependent. Clonal hematopoiesis starts at the age of 45, 50 to a significant amount, and then it's exponentially increasing. And meanwhile, we do know, for example, as I said before, that some of this is simply aging process of genomic instability. There are many processes associated with aging, which might also contribute to cardiovascular disease and especially ischemic heart disease. But in my view, this genomic instability is a major player, and beautifully, it's a player we actually can assess, because we can assess in individual subjects out of the blood by very easy techniques how many and what kind of mutations they do have acquired in their bone marrow cells. And I can tell you at the age of 70, if you measure precisely, more than 50% of even healthy subjects do have mutations. This is a normal aging process. But meanwhile, we do know that some of these driver mutations are associated with specific functional alterations in circulating monocytes originating from these mutated stem cells, which potentially gives us a treatment angle. And there are two things which are very important. I already mentioned the TET2 chip driver mutations. They are associated with increased inflammation, but the most common clonal hematopoiesis, it's not a mutation, it's the loss of the Y chromosome in men. And at the age of 70 years, 40% of men have at least 20 to 25% of their circulating leukocytes without Y chromosome encoded genes. And this is due to wonderful work by Ken Walsh, but also we contributed to that. This is due to an increase in diffuse fibrosis. So this loss of Y cells instigate a diffuse profibrotic response in the heart. And what's the classical age-associated heart disease? It's diffuse fibrosis leading to impaired diastolic function, potentially HFpEF, leading, if you have an infarction, to adverse remodeling. And if we can identify those patients who do have these mutations, and this is age dependent, and we might have therapies to interfere, we potentially would be able to call age no longer an unmodifiable risk factor, because we do know what kind of mechanisms are impaired or out of order during age. And this is actually what drives me at the time being. And you realize by speaking so enthusiastically about it, I really believe that this is going to add a completely new dimension how we actually foresee precision medicine in cardiovascular diseases, which I believe is one of the major tasks we have to fulfill in the future, to precisely define the therapies according to the risk. Our colleagues in hematology have shown us how beautiful it is to have this, in quote, molecular therapies. So this is what I do believe, and therefore, to answer your question, I do believe that those kind of things will enter the clinic. I hope I live long enough actually to see it and to also see the advantages of it.
We already have these tools as biomarkers, so the next step will be to carry them on to a therapeutic level.
Yes.
So I see that there are other, Eloisa still has another burning question. So please Please speak louder, Eloisa.
Microphone, okay.
Speak louder.
Okay,
It's
can
okay.
you hear me?
Yeah, it's okay.
Suppose, Andreas, suppose you have money to invest in this moment for genetics, and only one choice, please. Polygenic risk score or somatic mutations?
No question, somatic mutations, because they are age-associated, and age is the major risk factor, and the polygenic risk score, not including somatic mutations, if they would be included, which is currently on the way to be done in some of the analysis, for example, in UK Biobank, there are some data that including somatic mutations might actually increase the prognostic significance of polygenetic risk stratification. But if not, then I would bet my money on age-associated alterations, because this is what we are confronted with in cardiovascular disease.
Bravo.
Although it's not only ischemic heart disease, it's aortic stenosis. There's no more prototypical age-associated disease as aortic stenosis, aortic aneurysm.
Yeah.
Clearly, there's a clear-cut signal that this is age-related, and it might also be related to some of these mutations. But having said this, clonal hematopoiesis is not a unique entity. It's different genes, different dosages, which means different variant allele frequencies. So we have to be specific, and not one chip driver mutation is equal to another. It's potentially a bit easier by loss of Y, but loss of Y is completely different from loss of X chromosome, which is also prevalent, but it's not so strictly associated with cardiovascular disease. There are many ways to go and investigate this. And last point, maybe it's interesting for the entire audience, in all mammal species, males live shorter than females. This has nothing to do that young guys are more fighting, have more accidents, are killing each other or something. It's for all mammalian species. In avids, in birds, female birds live shorter than male birds. Guess why? They have a different chromosome. That the Y chromosome is with the females, and they lose it, and obviously they die earlier. There's a beautiful paper in PNAS in 2025, I think, got a science translation, beautifully showing this. So yeah, that's it.
Thank you.
Well, sorry, I missed the Wi-Fi before. I'm in China, far away, and
It's okay.
I've lost the Wi-Fi, but I'm enjoying this. It's almost midnight here, but I'm enjoying this conversation. And well, Andreas, thank you, because you publish a very well-cited paper in the European Heart Journal on loss of Y chromosome and events after TAVI. And Peter Libby wrote a wonderful editorial, and the title was Why? And you have explained very well why. I think is interesting. But by the way, as you are saying, women live longer than men, but there's an exception in Europe. This exception is in Sardinia. Nobody knows why, but in Sardinia, men live more than women. Might have something to do with the Y chromosome. We will see. But consider Sardinia as a place where to make some interesting investigations. Raffaele.
It's also a nice place to be.
Okay.
You can good collaboration.
Yes, the pleasure and the efficacy. Yeah. Raffaele, back to you.
Andreas, we are close to the end, but we like you to give advice to young cardiologists, especially to young cardiologists who are still fascinated by ischemic heart disease. You know that most interventional cardiologists now are moving out of ischemic heart disease, are going to structural valves and so on. But do you think we are close to the ceiling for, I guess no, for ischemic heart disease, still the main cause of death in Western countries. So, what would be your vision and your advice to young cardiologists?
So I think you're absolutely right. We are not by far not there yet in interventional cardiology, and especially with ischemic heart disease. I think we are on the way of transforming us from opening stenosis towards I would call precision cardiovascular systems medicine using imaging, both intracoronary as well as I said, this photon CT scanning, biology, maybe robotics in the future. I'm not convinced that for the interventional procedures this is necessary, but they need to integrate artificial intelligence because this will give us a completely different view also on how we characterize plaques, for example, from CT, without having our predefined meaning how this should look like. And for the young people, I have a very, very short advice. And the first one is be curious all the time, hard work, and don't accept dogmata. Dogmata are there to be unproven.
Broken.
And this is something where you have to be curious, you have to collaborate and work in a team. You have to respect the patients, which is, in my view, something which we have really to put more effort on. And for the people working, for the colleagues working in the clinical arena, think about reverse translation. Look at specific patients, look at their problems, and think about how could this be remodeled on a basic science pathway. I think your mentor, Attilio, was wonderful in looking specifically at patients, identifying specific things, which then turned out to be both by basic science, but also prospective studies to be important. And again, for the young people, be open to technology. And I don't mind going to structural interventions because valvular heart disease is probably more in the next coming years because it's a prototypical age-associated disease where we have absolutely no preventive measures as yet. But do not forget that even if you're an expert in replacing calcified valves, both aortic as well as mitral, as well as insufficient tricuspid valves, it would be much better actually to interfere before the valves become in a stage where they have to be removed. So think about pathophysiological mechanisms which drive these disease entities to treatment necessity. And this is something I think where we can actually nicely integrate interventional cardiologists and basic science people simply by looking at each other, talking to each other. And I think this is probably also the most rewarding thing for young cardiologists, that they do see that they, even if they work exclusively clinically, like I did for many years, that you can make an impact simply by looking at specific patients and ask specific questions to your basic scientists. So this would be my a bit longer advice for the young people.
Thanks very much.
Thank you, thank you very much. Very inspirational. Back to Attilio Maseri, he was a big fan of Karl Popper and the theory of falsification. Karl Popper theorized that the progress is based on the falsification or attempt to falsify current dogmas. And I think he's right, and Attilio Maseri was a strict follower of Karl Popper.
Yes.
But last question, I see regarding falsification of dogmas, I see you and Diana. Diana is our deputy editor for ischemic heart disease. Question, but really short answer. Are we overutilizing myocardial revascularization in stable patients, in your opinion? Let's try to falsify this dogma. Andreas and then Diana.
I have a clear answer. No, as long as patients have symptoms, because I think we have to get rid of this idea that we always want to prolong life. If you're 85 and you have angina, you feel much better if your angina is gone. And this is what we can actually do, especially for ischemic heart disease, by removing the obstruction.
Thank you very much. Diana.
I completely agree. I would also hazard to say that I remain unconvinced by the ischemia trial results for a proximal LAD lesion. And humbly, if I had a proximal LAD lesion that was critically stenosed, obviously with symptoms, but even in the absence of symptoms, I would probably prefer a stent rather than being medically managed. Once an interventionist, I think always an interventionist.
Thank you.
Well, we need a dialogue on this specific topic because it's extremely relevant. But let me come to a last question for Andreas. Andreas, if I well remember, this is something we discussed long ago during a dinner. You started as a professional tennis player, or really, you were very good. Never had the temptation to go for tennis rather than medicine?
Also clear answer, no, because I would not have been good enough. But I have to admit that I financed my time at the university by giving tennis lessons. This at that time was very famous. And I also financed, I spent actually 5 months in South America working in a hospital and 4 months in New Zealand during my time at the university. And this was all financed by giving tennis lessons. I once in life participated in a tournament in the Alsace in Strasbourg. And I actually made it over the first round. And I did get 25 French francs at that time as a prize money. This was all, but there was never an idea to become a tennis profi because, yeah, I wouldn't have been good enough. But it was good for making a good living and having a good time.
Yeah, so another message for our younger colleagues. If you don't have money to study medicine, please play tennis as a source of income. Okay, well, we are at the end of this wonderful conversation. Thank you, Andreas and Raffaele. It's been really lively and interesting and inspirational. I apologize again for missing contact for a few minutes, but this is the beauty of what is live. Thank you very much again,
Thank you.
We will meet as usual at the end of June, last Thursday in June, as usual at 17. And the next dialogue will be run by the weekly journal scan team. Carlo is here. Carlo, do you want to anticipate what will be the topic next month?
The topic will be to review ongoing approaches to downplay the inflammatory component of acute coronary syndromes with participation of Zalat, Libby, and Ridker. So top investigators in this field will review different approaches.
Well, Carlo, I would invite Andreas as well.
I would be happy to, yeah, of course. But Peter knows everything I know about clonal hematopoiesis. But don't forget diffuse fibrosis, Carlo. I think this is, for the heart itself, is especially important.
Sure. Thank you. Thank you, Andreas. Looking forward to seeing you in June.
Thank you very much. It was wonderful to participate.
Thank you again, and see you again at the end of June. Bye-bye.